Hello, I am Tracy Downs, Project Associate for Lifetime Learning in UVA's Office of Engagement. We have 982 people from 40 states, Washington, D.C., and 17 countries registered for today's Engaging the Mind presentation, Prostate Cancer from Diagnosis to Recovery. We are thrilled to welcome you. This program is in partnership with the UVA Cancer Center, and I would like to thank my colleagues in the UVA Cancer Center Advancement Office for their partnership in developing and promoting today's program. We received many questions in advance of this program. Should you have a question during the program, please add it to the Q&A box. Your questions will only be seen by the panelists and not the larger audience. You can also mark your question as anonymous if you would like to do so. Our speakers will answer as many questions as time permits. The chat box will be used to share resources with the audience during the presentation. We are recording this event and will post it on our website in a couple of weeks. Please keep in mind that our panelists are unable to answer any personal medical questions or offer any medical advice during the webinar. We are fortunate to have two University of Virginia physicians, researchers, and scholars with us today, Dr. Kirsten Greene and Dr. Tracy Downs. Dr. Kirsten Greene serves as Associate Chief Medical Officer at UVA Health. She was appointed the Paul Mellon Professor and Chair of the UVA Department of Urology in 2019. In this position, Dr. Greene provides urological services to patients in the community and trains the next generation of urologists. She specializes in caring for patients with cancer of the prostate, kidney, and bladder. She is interested in organ preservation and minimally invasive robotic surgery. Dr. Tracy Downs is a board-certified urologist specializing in the surgical treatment of urologic cancers with a subspecialty focus in the treatment of both prostate and bladder cancer. He also has extensive experience in taking care of patients with general urology health concerns and overseeing clinical trials. Dr. Downs joined UVA in 2021 to serve as UVA's first Chief Diversity and Community Engagement Officer. In this role, he serves as UVA Health's leading voice in diversity, equity, and inclusion, and as an advocate for related initiatives across the health system and the local community. Dr. Greene and Dr. Downs, we welcome you to this Lifetime Learning Engaging the Mind program, and the microphone is all yours.
Thank you so much. We are thrilled to be here. I'm going to share my screen. We have a lot of information that we're delighted to share. We're going to talk prostate cancer from diagnosis to recovery. So there are a lot of things. I want to thank Dr. Downs for being with me today, and we're going to just jump right in. So we were fortunate enough to get a lot of the questions that people had submitted early. So we broke this down into multiple sections, essentially kind of focus a little bit on prostate cancer screening, diagnosis, treatment, and then recovery, as well as resources and some future questions. So to kick it off, Dr. Downs is going to tell us a little bit about prostate cancer diagnosis and some background on prostate cancer. Dr. Downs.
Yeah, thank you so much, Dr. Greene. A pleasure to be here with everyone, and hope that you'll find this to be an engaging and low-stress opportunity for us just to think and talk about prostate cancer. So it is indeed a very common cancer. 1 in 6 U.S. men will be diagnosed in their lifetime with prostate cancer. 1 in 6 of these men who are diagnosed will actually die of prostate cancer, which is about 2 to 3% of U.S. men. It is the most common non-skin cancer in U.S. men, with 288,000 diagnosed each year and 34,000 individuals dying of prostate cancer. It's what we would call a common incidental cancer, meaning that it's very common for men to get it. The risk factors associated with prostate cancer are threefold, based on your race or your ethnicity, your family history, or based on certain genotypes or genetic diseases around BRCA1 and BRCA2 genotypes. This next slide here is giving you a sense of prostate cancer incidence. So on what we would call the bottom half, you see the years from 1975 to 2019. On the upward side, or we call the y-axis, you see rate of 100,000 per population. And at the first red arrow, we see prostate cancer in terms of the diagnosis. And a lot of this has to do with our early testing. And so the PSA that we'll talk about later has led to a lot of early diagnosis and picking up of prostate cancer. We see how much more common it is on this image relative to other common cancers, lung, colon, urinary, thyroid, and liver cancers. The second big red arrow is showing that what happened when the screening recommendations changed. So in this country, we were graded as being too robust in our screening, and that led to fewer tests, and you could see the big drop off in terms of the annual rate of cancer diagnosed each year, but that has gone up as we've now re-engaged with new screening recommendations. This next slide talks about stage at diagnosis. And in the red, that color is for all races. The green is for people who would be considered white. And then the blue is for those who are Black. And so localized means that we detected the cancer where it's still confined to the prostate, so the best case. And good news there is that 70+% of our cancers that we're detecting are localized and should respond well to treatment. And then you can see the other stages being regional. Maybe it went to a lymph node. Distant would be that it spread to a different organ or far, far away from the prostate. And then there are always some cancers that are unstaged. This next slide is, again, the same color scheme, looking at 5-year survival by race and stage. So again, a good news story here is that when we look at localized prostate cancer, meaning that if we detect it early enough, regardless of your race, whether it be white or Black, that your survival rate at 5 years outstanding, over 99%. As you start to even be in regional disease or local spread outside of the prostate to a lymph node, still outstanding outcomes. But once you get into metastatic prostate cancer, we start to see a big drop off down into the 30% 5-year survival rates. And this last slide on prostate cancer mortality really gives us a big view, almost 100 years, 1930 to 2020. And what we see here is that prostate cancer highlighted in the kind of brownish color, that it's been around in terms of mortality rates. And we're finally starting to see a dip as we've gotten into the early 2000s. That is a lot of the hard work that happened in the late 80s and 90s, where we started to launch early screening using the PSA testing. And now we're starting to see the prostate cancer mortality rates go down. Now I'm going to hand it back over to Dr. Greene to talk about risk migration.
Thanks so much, Dr. Downs. So along with what Dr. Downs was explaining, prostate cancer, there was a huge incidence of it when PSA screening started in the late 80s and the 90s. And as a result of that, more men were being diagnosed with low-risk prostate cancer over time. So you can see in the 1990s, it was only 27.5% of men had low-risk prostate cancer. That was right at the very beginning of PSA screening. Now in the early 2000s, you can see it was almost up to half of men were being diagnosed with low-risk prostate cancer, which seems like a good thing. However, this leads us into a little bit of the prostate cancer controversy. So again, PSA was discovered. PSA has always been around. It's a naturally occurring enzyme in the bloodstream that has a function in the prostate, but it was discovered as a screening tool in 1989, and screening started in the 1990s. Then prostate cancer led to more cancer being diagnosed. And in the early 90s and early 2000s, people thought all prostate cancer should be treated. What we're starting to understand and what we know now is that a lot of prostate cancer is being diagnosed 10 to 15 years before it ever would have been symptomatic. So that gives us what's called lead time bias. We're finding cancer very early. And what we're going to talk about a little bit over the rest of our discussion today in the next hour is the difference between diagnosing prostate cancer, treating prostate cancer, and recovering from prostate cancer. So again, PSA, discovered naturally occurring substance. Total PSA is the number that you usually see on your blood test. There's another test sometimes that can be used called free and total PSA, essentially measuring the amount that's unbound to the ratio that's bound in your blood to help us determine if the PSA is worrisome or not. Keep in mind, though, PSA levels rise as you get older. So older men have higher PSA. If you have a large prostate, it's going to make more PSA. So that's a naturally occurring explanation for a high PSA. African-American ethnicity can be associated with a higher PSA. Infection absolutely shoots the PSA up in a non-cancerous way. Trauma or instrumentation, meaning putting a catheter in, putting a scope in, these things will increase your PSA. And of course, prostate cancer does as well. So moving on to the question I get a lot, which is, when should we biopsy? What's an abnormal PSA? What's normal? What's abnormal? Well, there's a concept that was identified on a trial a long time ago called a continuum of risk, meaning that there's no normal PSA value. I often tell people it's not like a pregnancy test where it's positive or negative. If you take a look at this, you can see at every level of PSA, 0.5, there's a 6.6% risk of having prostate cancer. It's low, but it's not zero. And as you get closer and closer to 4.0 or 3.0, which is a common threshold, the likelihood of prostate cancer being diagnosed gradually increases. So today, often a threshold of 3 or 4 is used. This is the concept of a median PSA. What's the average PSA? So for someone in his 40s, a median PSA is 0.7. The 90th percentile, meaning the really high upper bound, is 1.48. So you can imagine a man in his 40s with a PSA of 3, that's really abnormal for someone in their 40s. Whereas if you're in your 70s, for example, the median PSA, the average PSA is 1.98, and the 90th percentile is 6. So the PSA rises as you get older, and there's different levels that are appropriate for different ages. Now we're going to look at screening recommendations. So the AUA is the American Urological Association, who recommends screening, meaning PSA testing. And I'm going to stop for a second to answer a question that we got quite often. PSA screening means a blood test called PSA is being used to test for prostate cancer. Prostate cancer screening today is always the PSA blood test and or a digital rectal examination. I mention this because some screening recommendations say that you should use both together, and some say you can just use PSA. But to be very clear, just a rectal exam, that is not an appropriate way to check for prostate cancer because it misses most of prostate cancer. And it goes back to the slide that Dr. Downs showed you where pre-1990, there wasn't much prostate cancer being diagnosed because there was no PSA. So bottom line takeaway from today, number one is make sure you get a PSA blood test, not just a rectal exam, if you want to be checked for prostate cancer. So now back to the screening recommendations. This is a little bit all over the place, and this is why it's hard to know when to start and stop screening. The American Urological Association says the average range is 45 to 65. The U.S. Preventative Service Task Force, thankfully, has changed their recommendation to allow for screening 55 to 69. American Cancer Society says start at age 50. The NCCN says start at age 45. And then the time to stop is usually about age 70 or when you don't have a 10-year life expectancy. And the value to biopsy at, it can be a lot of different values. American Cancer Society says 2.5, NCCN says 3.0, and the AUA doesn't give an actual threshold because the American Urological Association wants us to take more than just a PSA blood test into account. So MRI, risk calculators, and a variety of other things. So the screening controversy, why is this controversial? Well, studies have shown that you actually have to screen, mean blood test 1,000 men to save 5 men's life from prostate cancer. So you have to actually check and treat a lot of people for it to benefit any. What we've evolved from this is not identify everyone and treat everyone. It's identify everyone if we can, or identify the ones who really need treatment, but only treat the people who need it at the time they need treatment. So part of the controversy is if you screen everyone and you treat everyone for prostate cancer, you're actually going to have 130 people with unnecessary biopsies that they didn't need because they didn't have cancer, 35 people who are going to have bladder or sexual long-term side effects that don't recover from treatment, and then 8 people with complications of just the biopsy alone, such as sepsis or treatment, heart attack. Fortunately, less than 1 death due to treatment. But you can see prostate cancer, as we're trying to show, is a disease that we're catching very early, and not all men need treatment right away. So do the harms outweigh the benefits? Now, Dr. Downs and Dr. Downs is going to kick this off, just highlighting some of the harms and some of the benefits of prostate cancer screening and treatment again, to kind of clarify this point.
Yeah, thanks, Dr. Greene. And it really is that last slide was perfect. I just love it because it shows that, it's right. It's not a perfect science. But in this case, like if we took someone who did not have, and this is really a major take home point. So if you don't have 10 years life expectancy, then kind of getting on this roller coaster, so to speak, around getting your PSA checked and all of these things, it's likely that you're going to not live long enough to reap the benefits of having a prostate cancer detected and then treated. And so definitely for someone who's over 70, and it's still in 2023, it's not uncommon that we may get, be a new referral, someone who's age 73 who got a PSA. And then those are always kind of difficult conversations as we're trying to play catch up and educate our patients as well as our providers who refer that this is not the person to get a PSA in, because we're worried, and we've learned from our lessons in the 1990s and 2000s that we're probably going to cause more harm. And you see that as evidenced by, a biopsy is necessary, but it has some kind of, pain associated, not a ton, but a little bit. And then you can see the different complications. So that would be one example of where the harm definitely outweighs the benefit.
All right. Moving on, we're going to get to the next big question, which was prostate biopsy. Can you avoid it? Why do you need to have a prostate biopsy? Prostate biopsy is the way to diagnose prostate cancer. So MRI cannot diagnose prostate cancer. All these blood tests I'm going to mention, they cannot diagnose prostate cancer. We actually need a tissue diagnosis. Prostate biopsy can be done really two different ways. One is transperineal, meaning going through the skin behind the scrotum, avoiding going through the rectum. That has a very low infection rate, but a little bit more pain and a little bit more difficulty with urinating after the biopsy. The transrectal, this is the more common way. The needle actually goes through the rectal wall. And as you can imagine, this is going to cause some bleeding in the rectum and the bowel movement, some blood in the urine. It can also cause infection by pushing bacteria through the rectal wall into the prostate. But this is how we diagnose it. And why do we do this? Because we want to get your Gleason grade. So on the biopsy that's taken, the pathologist takes a look and gives it a score, which is a first number, 3 is the lowest it can go, and a second number if there's a secondary pattern. This is also called grade group. And essentially what we're trying to get is the score or the grade group of the cancer to determine whether or not it needs treatment or is appropriate for active surveillance. Generally speaking, Gleason 3+3 is considered very slow growing, very non-aggressive prostate cancer, grade group 1, that in many, many cases, if not most cases, does not need treatment. There's even a controversy right now about whether this should even be called cancer. So that's the role of prostate biopsy, and that's the Gleason grade and the pathology. Are there alternatives to immediate biopsy? I mean, no one's really excited to get a biopsy, right? There are alternatives. But the end of the road is biopsy to make a definitive definition of prostate cancer or not prostate cancer. So what are the alternatives? Before your first biopsy, you can get the free PSA, as we talked about earlier. That's a blood test. PCA3, it's a urine test. Phi or 4K, they're blood tests, but you can't use these if you're on dutasteride or finasteride. And an MRI of the prostate, that's a type of imaging that actually looks for an abnormal area in the prostate, and that increases the sensitivity and the specificity of the biopsy. So essentially, it gives you the most accurate biopsy you can have. Now, before you do a repeat biopsy, there are other things. There's Confirm MDX, which is a tissue test. Again, you've got your free PSA, your PCA3, your Phi, your 4K. So blood tests, what these do, blood and urine tests, help to refine your risk, because we don't really want to find people with Gleason 3+3 prostate cancer, because they usually don't need to be treated right away. But we do want to find people with more aggressive or higher grade prostate cancer. And that's why we can use these tests to improve the specificity.
Dr. Greene, can you talk about free PSA just in case, like what is that what is the typical test that everyone gets, or how's it different?
Free PSA is an easy test. Everyone can get that. It doesn't matter where you live, you can get a free and total PSA. It's just a blood test that breaks your total PSA down into 2 fractions and gives you a ratio. So that one's easy. The other ones, 5, 4K, PCA3, they can be a little harder to identify or to get depending upon where you're getting your treatment. And then MRI prostate, that's available to most people, but not to everyone. And so I have another slide. Again, the point of it is to try to determine who has Gleason 3+3 that we probably don't need to identify, and who has this higher grade disease that we want to identify. And that's what those blood tests help to predict. It can't diagnose you though, it just predicts the likelihood. So again, these are the different tests, and this is a couple additional tests, and it shows the components for anyone interested in that. And this is an algorithm. If you've had a negative biopsy in the past, because that's really frustrating, I think, as a patient, where your PSA is up, you get a biopsy, it shows no cancer, your PSA continues to rise, and you're like, what do I do next? So the next best step in that case is get an MRI of your prostate. That is the answer in all cases. Now, some patients can't get an MRI, right? If you have a pacemaker that's not MRI compatible, if you have an aneurysm clip, or maybe you live somewhere you don't have access to an MRI. In that case, so if you have an MRI, then get that. If you have a PIRAD score greater than 3, get a biopsy. If you don't have one, you can get a blood test called a marker or a urine test. If you can't get an MRI or you don't have access to it, then one of these markers is a great thing to use to determine whether or not to get that next biopsy. So we were going to go on now to prostate cancer treatments. There's a lot of different options, and Dr. Downs is going to talk about the first option, which is active surveillance.
Thanks, Dr. Greene. Yeah, so active surveillance kind of came on the scene, many, many years ago, but just to not confuse people, before that, again, going back to the 1990s, early 2000s, we had a term called watchful waiting. And so watchful waiting was something that when you were diagnosed with prostate cancer, and again, we were still learning a lot then, but let's just say you were 73, or let's say you were 65, but you didn't have a 10-year life expectancy, and we didn't want to do more harm than good or benefit, then in those cases, we would just follow someone. So there was really no intention to actually treat, let alone cure that prostate cancer. So that was watchful waiting. So let's not confuse that old kind of approach, watchful waiting, with active surveillance. So active surveillance is really being actively engaged in surveying a patient and deciding when to treat, and knowing that if you do treat, you're still able to actually come out with a good outcome. So the goals of active surveillance are avoid or delay the costs, functional or monetary, of treatment without compromising cancer cure. And based on the rationale that the initial assessment is reasonably accurate, and then we can actually monitor over time. So if you fall into that category that Dr. Greene talked about, say a Gleason 3 and a 3, so a 6 total, or group 1 that we don't really want to treat, we can then actually follow you over time with those markers or PSA tests, possibly an MRI, and then reevaluate with serial PSA tests if we should actually come off of active surveillance, or if it's safe to just follow this cancer with no risk of it actually spreading.
Exactly right. Thank you very much, Dr. Downs. All right, I'm going to talk a little bit about the treatments for cure. So surgery and radiation are considered contemporary treatment for cure. So not active surveillance, but active treatment to get rid of the prostate cancer or cure it. They're equally good. And I want to stop there for a second because I'm a prostate cancer surgeon. It's what I love to do. And I'm telling you, they are equally good. This is based on level 1 evidence from a clinical trial that compared active surveillance, surgery, and radiation, and they have equal outcomes, meaning both are curative. A lot of people think that surgery, because it's harder or it's worse, or instinctively you cut it out, why could anything be left behind, is more of a cure than radiation. But the way that they're done nowadays, they're equally good. So the side effects of surgery are urinary incontinence, not stool, but urinary incontinence that improves, generally speaking, over the course of a year for most men, but does not as a guarantee go away. Erectile dysfunction that's immediate and usually recovers over 3 years. Penile shortening can be up to 1 inch. Infertility, which is immediate. No more ejaculate comes out, so the sperm's trapped in the testicles. Now, in terms of backup plan, what if you do surgery and some cancer cells are left behind? You can do radiation in any of its form, as an adjuvant, meaning both together, or as a salvage, meaning if your PSA comes back and rises up, which Dr. Downs is going to talk about in a bit, you can do radiation as your backup plan. Now, radiation, equally good. It doesn't cause incontinence, but it causes frequent or urgent urination because the bladder's irritated. It causes some bowel irritation, which today is very minimal because of a gel that's inserted called Spacor. It does also cause erectile dysfunction, but not right away. Surgery causes erectile dysfunction right away, and then it recovers over 3 years. Radiation, erections are kind of stable for 2 to 3 years and then get a little bit weaker. It causes infertility, not right away, but over time. And then if the radiation, let's say, doesn't work or works for a little while and the cancer comes back, then you can do androgen deprivation therapy in almost every case. You can do a little more radiation. You could do freezing. We usually don't like to do surgery in this case, although it's possible because the side effects are so bad. So a lot of people say, why not just treat everybody and get rid of the cancer? And the reason is both of the curative treatments impact your quality of life in a negative way. If there were no side effects, then of course we would treat everyone, but it's a balance between treating everyone and maintaining excellent quality of life for patients. So again, radical prostatectomy, it damages the nerves that wrap around the prostate like a spider web, and radiation damages those nerves too with the radiation. The bladder and the prostate and the urethra, they're all in line, they're all attached. And so when you take out the prostate, you're cutting some of these sphincters, and that impacts the urinary function. Whereas if you're radiating the prostate, those are also getting a little bit of damage, but they're still there. And that's why there's no incontinence, usually speaking with radiation. Now, focal therapy is something people are really excited about. It's been around for a long time, but what essentially this means is either freezing or cooking with ultrasound or an electrical current, a small amount of the prostate. It's unclear whether this is curative for a long time, but it could reset the clock on active surveillance and just get rid of a dominant bad lesion in the prostate. Salvage options are the question, though. You know, I mentioned that after surgery, radiation is a salvage. After radiation, you get more radiation. What's not so clear is what's a good salvage option after focal therapy. So this is being investigated even more. Dr. Downs is going to mention a little bit about prostate cancer recurrence. We had a lot of questions about this. You know, what counts as the prostate cancer coming back?
Yeah, thanks, Dr. Greene. And this one can trip up people quite a bit. And so just kind of thinking out loud a little bit. So when the different treatment options that Dr. Greene showed, if you have your prostate removed, then again, that's the main source of PSA production. So we would expect that your PSA should be below this threshold. So it never goes to 0.000, but it does go below this 0.2 range. And so when you get your PSA post-op or after your surgery, it should be below one of those thresholds, and then it should stay there. After surgery, once it gets above this 0.2 nanograms per ml, and we then recheck it and we get a second value that's again above the 0.2 nanograms per ml threshold, then by definition, you have prostate cancer recurrence after surgery. Now, the radiation definition is a little bit different, and let me explain it to you. So in radiation, we don't physically remove the prostate, and so it's still there. And so it may be emitting off a little bit of that PSA into your bloodstream. And so we follow it, and over time, that PSA will go to its lowest point. And that lowest point we call the PSA nadir, NADIR. Now, sometimes when the PSA is getting to that nadir, and this was something I learned when I was a fellow doing urologic oncology, you would suddenly get this bump, and they would call it PSA bounce. And so a patient would come in and their PSA had been kind of trending down, 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 and all of a sudden, boop, it will go up. And then they'd come in and they were nervous, and you're nervous as you're learning things. And then what we found out over time is that was natural. So it's kind of this little bit of more release of PSA into the bloodstream. And then eventually it should get to that nadir, NADIR. Once it's at that nadir, once it gets 2.0 or a value of 2 above that nadir, so if your lowest was, let's just make it up, on this case it was 0.4, then once it gets above 2.4, then you actually have recurrence after radiation therapy. And that doesn't matter whether it's external beam or whether it is brachytherapy when you get seeds implanted.
All right, I'm going to mention a little bit about tests and new directions, tests and tools. and also shows some things that we have here at UVA. So this is called a PSMA PET scan. I'm proud to say that UVA was one of the facilities that actually helped to validate this and prove that it is a safe test. It's a PET scan that specifically finds prostate cancer that has spread. The little arrows that are going to be popping up on the screen are lymph nodes that have prostate cancer in them, and you can find some prostate cancer in the prostate too. Now, this test is widely available. It's FDA approved. It should be covered by insurance, and it's used in recurrent prostate cancer, so the case that Dr. Downs just mentioned, or newly diagnosed high-risk prostate cancer to help us determine if the prostate cancer has spread or not. So this is a new thing. And then another new thing is the same idea. So it's the PSMA little molecule that sticks on the prostate cancer. But in this case, it actually, instead of lighting it up so we see it on a PET scan, it actually dumps this little radioactive molecule on it to kill the cancer. And that's called Pluvicto. So this is just a snapshot of a patient who had the black spots or widely metastatic prostate cancer treated with Pluvicto multiple times. And you can see over time, this is a treatment that can get rid of a lot of the cancer. It doesn't get rid of all of it, but this is something that's new and really exciting and really hopeful for men with metastatic prostate cancer when the cancers come back. We have that at UVA as well. So now we're going to talk a little bit about the road to recovery, because part of the way most people choose which treatment they want is among the sexual side effects, the urinary side effects, fertility, and their overall well-being. So we're going to touch upon these. We're going to start with penile rehabilitation, addressing the issue of erectile dysfunction after surgery or radiation. Penile rehabilitation is the idea that we want to get your natural sexual function back. Of course, the medications are the easiest thing, starting with Viagra many years ago, the little blue pill. There are a lot of other pills now, Levitra, Cialis, and there are studies that actually show that if you use these before the surgery, before radical prostatectomy, or potentially with radiation, you actually regain your function a little bit better. So similarly, there's something called a vacuum pump, a vacuum erectile device. This, if you can't take the medication because you're on nitrates, or if it doesn't work for you, or you have bad side effects, this doesn't matter if you have intact nerves or if you are allergic to the medicine or can't take it for some reason. It's an actual device, it's a vacuum device that's placed on the penis that vacuums blood into the penis mechanically. And so these studies looked at what if men use the vacuum pump and the oral medications. Again, these are done after surgery, but you can imagine they could be done after radiation as well. And what they found was better function and less penile loss with the use of both of these together. Now, intracavernous injection is really scary to some people. It's the idea you have to actually stick a needle into the penis and inject a medication. It works extremely well, and sometimes it works a little too well, which is called priapism, when the erection doesn't go away. But studies with this actually found that if patients were able to do this early on, they not only had better early sexual function because the medication works so well, but over time it helped the Viagra itself, just Viagra without the shot, actually work well on its own. So the concept here, and these are other therapies, is to try to regain that natural function over time. Something else really exciting we have here at UVA is low intensity shockwave therapy. This is an idea of trying to regenerate adult stem cells in the penis, and it's a low intensity shockwave given to the penis to try to recover natural function over time. Again, something we have here at UVA, and this was the pioneering article by Dr. Liu. So fact or fiction, we actually focus on this a lot at UVA. We have what we call prehabilitation, offer you visits with Dr. Ortiz and Dr. Smith, they were kind enough to share the slides, to not just preserve the penile length, but also regain your function back naturally. If that does not work, penile prostheses, just to make you aware, are available and have a very high level of patient satisfaction. Dr. Downs is going to talk a little bit about continence recovery as well, and some things we have at UVA.
Yeah, thanks, Dr. Greene. And it's really nice, and it's such a lot of thoughts, right, when you're selecting your treatment, and to know the things that Dr. Greene just shared about kind of erectile dysfunction and kind of being able to overcome what seems like at first an unsurmountable kind of barrier. And so I'll switch gears and talk about urinary continence recovery, which is also something that's really important for our patients. And often at times that's one of the key factors in them deciding between to go with surgery or radiation. This picture is actually a really good one. I'm going to take a little time to walk you through it. So above we have kind of this rounded or semi-round area, which is the bladder. And then the green area is what would be called the internal sphincter, or sphincter that's right near the bladder. And then you've got this heart-shaped object, which is the prostate, and then this red area, which almost looks like a scarf around your neck, and that would be the external sphincter. And so the lines from A to B are actually when you actually cut out the prostate. And then now, if we could go back to that slide for just 1 second, Dr. Greene, you're now left dependent usually on your external sphincter or the red one. And so that's a very different muscle that is not automatic, and you actually have to learn how to train to regain your continence. And on the next picture, what you'll see is just a little bit of a side view of where those cuts are made. And then you see again urethral sphincter, and then you see the one closer to the bladder, the internal sphincter, and then on the right you see the separation of the two. Prostate's now gone. And then with Dr. Greene's fancy suture work and expertise, she'll then sew things back up, which she does really good. She's amazing. And then you will now start to work on your continence. We're proud. This is another area we've been working really hard here at UVA. And so one of our colleagues, Dr. Rapp, has developed, this is H Fitness. It's a free service. You can just, you see it there, hfitness.com. And it can help you regarding your continence, whether you've had prostate cancer surgery. It also can help with continence if you've got a friend, maybe of the different gender, from men to women. And it's just a great resource. And this is the last plug around Kegel exercises. So at least I'll speak as myself as a man. We don't often understand our pelvic floor muscles really good. We love our biceps, our triceps, we're flexing pecs left and right. But when it comes to pelvic floor and you try to teach, or at least my experience, a man about Kegel exercises, they're all moving their shoulders up and things like that. But it's really a muscle that's very low in your pelvis. And so this training will help you to do that. And it's really essential as you regain your continence quickly. So Dr. Greene is going to talk about fertility and the importance of that as a consideration, and also the road to recovery.
Now thank you so much. This is just a very quick, there's not much to this one, because essentially if you want to preserve your fertility before surgery, you absolutely have to sperm bank. The prostate's gone. There's no way for the sperm to get out. After radiation, you can preserve antegrade ejaculate usually for 1 to 2 years. So I think that's just something really important to know. Sperm bank, if it's important to you, talk to your doctor about it before either treatment, but certainly before surgery. And then Dr. Downs, you're going to talk about testosterone.
Yeah, thanks, Dr. Greene. And so testosterone is a really important hormone. And so I want to kind of establish a few kind of foundational things. So one is almost all prostate cancers need testosterone to grow and survive. And so I'll often give the analogy that to prostate cancer, testosterone is almost like the gasoline. So you need the testosterone in order for prostate cancer to grow, or we'd use the fancy word proliferate. Now, if you're a person who has a low testosterone, the good news is that it is safe for us to replace your testosterone to normative levels, and it will not increase your risk of prostate cancer. Now, where it becomes a little bit muddy and kind of controversial is if you are an individual and we're doing active surveillance, then we worry about testosterone replacement, because we may tip you over into a cancer that could have been surveyed and not required treatment into something that now requires surgery or radiation. Now, the prostate gland does not make testosterone. It's actually also made from our adrenal glands, which are these little caps of tissue above our kidneys. But we use androgen deprivation therapy, which we call hormonal therapy, to actually lower testosterone. And it's a way to stop prostate cancer when it starts to recur. And so unlike maybe hormonal therapy in women, where it's maybe hormonal replacement, when we talk about hormonal therapy in men, in this case, androgen deprivation, is we're removing that hormone testosterone. And there's been a lot of great studies recently, probably like the last 5 to 8 years, that talk about how androgen deprivation therapy in combination with other things actually can lead to very good outcomes if the cancer comes back. But androgen deprivation therapy in itself, if we were to do that, is not curative like surgery or radiation are.
Yeah, that's a great summary. And I want to just say a few words about androgen deprivation therapy and the side effects, because it's not a therapy we just give to everyone for a really long time any longer. By making the testicles stop testosterone production and making the adrenal glands stop testosterone production, it can make bones weak over time. It can cause hot flashes, weight gain. It can cause increased risk of heart disease or diabetes. And so there are bad side effects to androgen deprivation, despite the fact it's really important for prostate cancer treatment. And so that's part of the reason why, maybe different from 20 years ago, we don't just put everyone on androgen deprivation therapy any longer, because testosterone is important for overall health. So we've given you a very brief overview of so many prostate cancer topics. There's so much more to talk about, so we wanted to save time for some questions, but I want to just show a slide. These are some useful resources, and a lot of the information we've discussed with you today, you can access on nccn.org, the AUA, to look at different guidelines. This is completely free. It's good for everyone to take a look. You can see the algorithms, you can see the actual science behind these recommendations, and you can see how it changes over time, because every year these are updated and they're different. I also want to put a plug in. We have a prostate cancer support group at UVA. It's once a month. It's on the first Tuesday of every month at 6:30 at night. It's by Zoom. And to be part of this, you just need to email the email that I have on the screen. And that is how you get your individualized Zoom link. Everyone is welcome, and we just get together and we talk a little bit. We always have a physician there for the first 15 minutes in case patients have questions about their treatment of others, just things they've read in general. And then it's a private time for patients to get together and talk. So last slide is just my email. If anyone has questions, I'm always happy to answer questions or share information about what we have at UVA. And I just want to say thank you again for letting us speak today. And I know we have some additional questions to answer. So thank you very much.
Thank you, Dr. Greene. Thank you, Dr. Downs. That was a lot of very usable information in 45 minutes. Thank you very much. We do have several questions coming in right now, and let's get as many in as we can. The first one: does getting a prostate biopsy increase the likelihood of spreading any cancer that may be found? Or is it better to skip the biopsy in hopes of keeping the cancer contained within the prostate?
I can start off on that one. So remember that the only way to diagnose prostate cancer is with a prostate biopsy. So there is no other way to diagnose prostate cancer other than having a prostate biopsy. Unfortunately, prostate cancer is not a type of cancer that spreads with biopsy. Now, there certainly are certain types of cancer. One that comes to mind is testicular cancer. We would never biopsy that to prove it, because that spreads with the biopsy. But with prostate cancer, fortunately, it doesn't. And the reason I can say this with certainty is, if you remember, Dr. Downs mentioned there's about 288,000 new cases diagnosed each year. Only about a quarter of biopsies actually show cancer, which means over 1 million men are being biopsied every single year in the United States to determine if they have prostate cancer or not. Even if it was like a 0.001% likelihood of prostate cancer spreading with biopsy, we'd know it. We'd have a lot of cases because there are so many people getting a biopsy. So hopefully that reassures people that no, the biopsy does not spread the cancer, but then also it is the only way to determine if you have cancer or not. So it's necessary.
Thank you. Dr. Downs, do you have anything to add, or would you like for me to go to the next question?
Yeah, let's go to the next one just so we can get as many in as possible.
Sure, certainly. Thank you. What treatment options do you recommend for early stage cancer that is still contained within the prostate?
Yeah, I can take this one, and I think Dr. Greene covered it really well. Is that again, that's the localized, that's the buzzword. So it could be active surveillance, depending if you're in the good group, meaning you're the 3+3 or group 1. And you meet certain other criteria, or you could get surgery, or you could get radiation. Those are the main ones. And again, I guess there's a newer area around kind of the heating, cryo, or kind of the focal therapy. But I would say the bedrocks are really active surveillance, radiation, surgery.
I agree with that. And I think building upon that a little bit more, there's a concept of risk category. And if anyone goes to any of those websites that I listed, you're going to see it again and again, risk category, low risk, very low risk, intermediate risk. And so there's so much more to prostate cancer than just stage. It's your PSA, it's your Gleason grade, it's how many cores had cancer in them, meaning how many of the biopsy specimens had cancer. It's the presence or absence of some really bad patterns like cribiform or introductal, which we didn't get a chance to talk about because it's everything about prostate cancer in 40 minutes. But if you have very low risk or low risk prostate cancer, all the recommendations say active surveillance is the way to go. When you get into intermediate risk, as long as it's localized or even high risk disease, that's when you're really choosing between surgery and radiation for curative treatment.
Thank you. What is the best way to choose among options?
Dr. Downs, you want to take that?
Yeah, we can. And this is the great thing is you get a couple of different kind of views and perspectives. So, I think you sit back, right? And oftentimes it's hardest to make your best decision in an exam room. So I say you get all the information, things I learned long time ago, bring someone with you. So you get another set of ears and eyes. It's okay to bring a tape recorder so you can remember what was discussed at the time in terms of options. You'll probably forget most of it. And then I think it really does center down on some of the implications of therapeutic or treatment around urinary function, around sexual function, and then around cancer cure. And it's really kind of those three big areas that kind of tend to tip the treatment in one direction or another. I think Dr. Greene, you'll probably kind of hand it off back to you in terms of maybe if someone was younger and say it's maybe a 45-year-old or, a 52-year-old, you may think differently in terms of benefit of surgery over radiation based on that person. But those would be some kind of initial thoughts around that treatment options.
I think that's a great way to start. I mean, you have to, number one thing I would say, the way to decide, get a second opinion. You cannot make a decision about prostate cancer based on one opinion alone. It's a cancer that grows slowly. You have a lot of time to make up your mind, and you are going to live for the rest of your life with the side effects of whatever you choose. So make sure there's side effects that you can live with. Make sure that the side effects you choose that are your priority, because your sexual function is going to be impacted in a really personal, meaningful way. And you're going to recover. We just went over lots of ways to recover from these treatments, but you're still going to live through it. And the same thing with your urinary function, and the same thing with your androgen function, your testosterone levels. So think about how you want to live the rest of your life and realize you're going to be cured of the prostate cancer, or it's going to be controlled, but you'll be alive with those side effects. So number one, get a second opinion, take a minute, talk about it. Go to a support group, go to a peer support group, try to get a real sense of what your life is going to be like either way. Some people really like to think about a backup plan, meaning, okay, if number one thing doesn't work, if surgery doesn't work, what do I do next? Or if radiation doesn't work, what do I do next? Some people have really bad urinary function because their prostate's big. So they're urinating all the time. So surgery might be nice because it'll take away those problems and also get rid of the cancer. For other people, they've got perfect urinary function. They don't get up at all, and they, great strong stream, and they really prioritize their sexual function, and they'd rather keep it at all costs. And maybe it might get a little worse over time. Maybe for those people, radiation's better, or maybe for somebody with a tiny little bit of more aggressive cancer, maybe focal therapy is right for them, depending upon their age. So anything can be right for you. It just depends upon your own unique values and how you want to live your life. And that's why you need a second opinion, and you need to take time and talk to your friends and talk to your family and talk to your physicians and come to an end result that is going to work for the rest of your life.
Dr. Greene, if I could, I just love that answer so much. And again, how do you choose your physician and surgeon? Someone who's honest, right? So right off the bat, she said, get a second opinion. I mean, that's rare in modern days in terms of, and also for the patients and for if you're helping out one of your loved ones, don't feel pressured, right? We just showed you that this is a cancer. It doesn't spread rapidly. So if someone's making you feel like you need to make a decision that day, or they're saying, oh, I can get you on the OR schedule next week, or 2 weeks from now. It's a couple things that come to mind with that. One is probably the person's not that busy, because if they can get you on the surgery that quickly, then they're not probably operating a lot. And then that's just not how this cancer behaves. It's a cancer, but it isn't like something where you need to feel pressured. And it really resonated when you said, Dr. Greene, that, you're making these choices and you're going to have be left with the potential side effects. So make an important and an informed decision. So thanks for saying that.
Well, thank you. And the one other thing I want to mention is get an MRI. If you have just been diagnosed with prostate cancer, you didn't get an MRI first, don't have surgery or radiation without having an MRI first. It is always covered by insurance. And sometimes the biopsy misses something, right? Maybe it misses something really important that would change your mind about how treatment would go or what you would choose. So that's my other recommendation, is get an MRI before you choose your treatment. And I want to also double down on don't let anybody rush you into treatment.
Thank you. All right, let's continue on and see how many more of these we can tackle. This one, we have a couple of questions in this ilk. Is an enlarged prostate indicative of cancer or some other issue? And what are the implications of hyper enlarged prostate?
It's such a good question. Dr. Downs, you want to tackle that?
Yeah. So usually an enlarged prostate is not cancer. So it's usually just something we call BPH, or benign prostatic hyperplasia. And that would tie in with maybe your PSA might still be elevated above that threshold of 3 or 4, but it's not from cancer, it's from the enlargement. Hyper enlarged, I'm not so sure what you mean by that term, but a normal size prostate in a US male would be somewhere in the 20 to 40 gram or cc size. So something that maybe was 60, 80 would be more of maybe a hyper enlarged or a very large gland. But usually a big gland is not bad. And usually symptoms for men are indicative of enlargement, non-cancer, not indicative of cancer.
Yeah,
Okay.
that's absolutely right, because we use PSA testing, right? So we're finding, your PSA is elevated. We're finding prostate cancer, remember, a decade or more before it would ever be manifest as a symptom. So men presenting now with urinary symptoms, it's BPH, it's not prostate cancer, because it's not, 1985. And thank goodness we are checking with PSA. Not a perfect tool by any means, but definitely helps us. And yeah, big prostates, they're supposed to make more PSA by their nature. So not worrisome for prostate cancer in and of itself, just being big.
All right, thank you. 2 questions about finasteride, and I may be pronouncing that incorrectly, so
That's
please
perfect.
correct me. Okay, what are the guidelines for men who are on it, and does it affect the PSA results and make them lower than they actually are?
Yeah, finasteride and dutasteride, by their nature, they artificially decrease the PSA by half. So whenever you have a PSA of 2 and you're on one of those drugs, you have to double it. So if you are on finasteride and you get a PSA and it's 2, your PSA is not 2, it's 4. And the longer you've been on it, after a certain period of time, maybe like 8 or so years, then the multiplier becomes like 2.4. So artificially decreases it. And you just got to remember that. That's why it's important on active surveillance to know, are you taking finasteride or are you not taking finasteride? Because if you're kind of not taking it consistently, your PSA is all over the place. And on active surveillance, we follow PSA along with the MRI and the biopsy. So it's one of the critical variables.
Thank you. What would the PSA screening per 1,000 men look like for a 70-year-old?
I'm not sure what that question means.
Okay. I think it's referring back to the slides in the beginning that gave the.
Yeah, I think when you had the 1,000 men and you have to do screen 1,000 men to treat 5 to save them from dying from prostate cancer. So if we were to extrapolate that into
7-year-olds, I'm not sure. I mean, it depends on their PSA.
Right.
So
okay.
we can't do it for just one person. We'd have to know their PSA.
Okay.
Yeah.
Thank you. Can you speak to the number of samples taken during a biopsy and if there is any significance to the number of samples that may show abnormal result?
Yeah.
You want to start first, Dr. Greene?
Yeah, sure. So there's guidelines about the minimum acceptable number of samples. And it's historically been 8, meaning to have an adequate biopsy, you have to have at least 8 samples taken. I think that's changing a little bit. And now the minimum number of samples is 12. At UVA and a lot of other big medical centers, the minimum is 14 to 16 because we also take anterior cores. We don't just biopsy the back of your prostate, we biopsy your whole prostate. So we get a good sample. So yeah, going in and just taking 1 or 2 samples is not adequate. You actually have to repeat the biopsy because we want to know what's going on in the prostate. If it's worth doing a biopsy, it's worth doing it right.
Yeah, and it's an interesting part of prostate cancer science and the knowledge we've gained is because we started with what was called a sextant or 6 biopsies way back in the day, and then we found out that that was inadequate, and people have actually mapped out the zones of the prostate cancers Dr. Greene is talking about in terms of anterior, posterior, transitional. So we know where the prostate cancers grow, and the good news is that prostate cancer grows in the peripheral zone, very different than where BPH or enlarged prostate grows. And so just that in itself helps in terms of detection. And then, yeah, usually the 12, and then for the fans of anterior biopsies is making sure you get those areas. Really important. Maybe, Dr. Greene, I don't know, based on race of a person, if you feel a little bit stronger in terms of those anterior base biopsies, if that kind of tips you one way or another.
I mean, I do it on everyone because that's how I was trained. And now he and I were trained at the same place. So we both were trained to take anterior cores. It does increase detection. 20% of the time, cancer is going to hide in the anterior prostate. And so if you just biopsy the back, you're missing 20% of the cancer.
Wow. Okay. Thank you. Let's wrap up with this question. And we think it's a very optimistic question. Are there any, is there anything we can do to prevent or reduce the risk of prostate cancer?
It's a great question. Tracy, do you want to start off?
Yeah, maybe I could start and then have you bring us home. Yeah, it's a really important question, right? And so those complex questions sometimes have multiple layers of answers to them. So are there some things we could do? Yeah, diet. We know that diet can play an important role. There's been some trials done that have looked at diet, like there's something called the Mill study that's out on the West Coast, and it looked at a lot of things. And at the end of the day, it didn't show that maybe diet as well could do, achieve things. Maybe in a more of an active surveillance or a smaller non-threatening cancer, there might be some chances. And we've looked at things around soy, there's around tomato products and all of those different things. I think just trying to live a really healthy lifestyle. So we'd almost say a heart healthy diet and lifestyle should benefit not only your heart, but your prostate as well. And then this could be maybe an exception to the rule, but I remember this might have been maybe 2006, 2007, before I came to UVA. We had a patient with really aggressive advanced prostate cancer, and we put him on a trial where we used soy-based products. We also did yoga, did a lot of different things. And it just happened to be his wife was a gourmet cook, and his PSA responded to every single thing under the sun. So there are sometimes instances like that, but those are kind of my thoughts. How about you, Dr. Greene?
I would echo diet. So, low fat diet, low red meat diet, those tend to kind of track with prostate health and prostate cancer health. Exercise. I mean, it's unbelievable what exercise can do in terms of reducing cancer risk or helping to stabilize cancer. And then kind of going back to where we started, prostate cancer screening. So the way to, it's not going to prevent prostate cancer, but in terms of preventing the risk of prostate cancer, knowing what's going on with your own body, making your own decisions, being your own advocate, prostate cancer screening with a PSA, not just a rectal exam, at some of the ages that we showed, and asking questions, and don't stop asking questions if you're not getting the answers that you want. Those are things to reduce the risk of prostate cancer, I think, overall.
Thank you. Thank you both so much. Just to remind everyone, this has been recorded and will be posted on our website in approximately 2 weeks. So you can revisit this because definitely full of of very useful and helpful information. Thank you, Dr. Greene and Dr. Downs, for this informative and educational presentation on prostate cancer over this past hour. How fortunate we are to have both of you at UVA Health and in our community. We're very appreciative of your time and expertise. Thank you so much.
Thank you.
And thank you for your participation today. We hope you will join us for future Office of Engagement programming, both in person and online. And we invite you to check out other Lifetime Learning programs, the Vodcast Library, our Thoughts from the Lawn blogs, and our UVA Speaks podcast series, to read, watch, and listen to our expert UVA faculty. For all of this wonderful programming, plus the recording of today's webinar, please visit engagement.virginia.edu/learn. From all of us at Lifetime Learning, thank you for joining us today, and we look forward to our next shared learning opportunity with you, and we wish you a great rest of your day.